eight countries in 2 weeks.
8 countries in 2 weeks, my God.
Yeah, it's by boat, so it's going to be very interesting. I just hope I have high-speed internet on the boat. That's my only, I need that umbilical cord back to society.
Where is this? Southern Africa?
Starting in Ghana, I'll be working there for 3 days and then go Ivory Coast, Liberia, Sierra Leone, Guinea-Bissau, Senegal, and I'm leaving one out. One other,
So
yeah.
You're doing this for the Hepatitis B Foundation or?
Yeah, it was a vacation with my daughter, and I said, that's not my kind of vacation. I want to work. And then every major port, I'll be meeting with either advocates, providers, or Ministry of Health, or some mixture. Each country is going to be a little bit different, but I've got connections now in all the countries. Ghana, I'm going to go and give talks in 3 different cities and learn, because I'm there as a student. I'm not there to teach them anything. I'm there to learn and connect with Hepatitis B Foundation. So it's an ambassador type trip. And I also may take this machine called High Sky with me. It's one of the new, very small, portable elastography devices, which has a very good price point. So that'll be another part of the trip if that works out.
Oh, that's interesting. Okay. A US product or from somewhere else?
It's from China.
Let's start it.
Okay.
Dear Professor Hamid, dear Professor Gish, dear colleagues, ladies and gentlemen, we are very honored to have a very distinguished 2 speakers in Turkey on this Zoom meeting. So first, Professor Saeed Hamid will talk about the hepatitis B guidelines, new guidelines for WHO. So I would like to introduce him. Actually, he doesn't need to be introduced, but you know, just shortly I will introduce him. Saeed Hamid is a professor, Department of Medicine, and the director of the Clinical Trials Unit at the Aga Khan University, Karachi, Pakistan. He formerly served as chair, Department of Medicine, from 2008 to 2018. He trained in medicine and gastroenterology in UK, and also hepatology at University of Texas Southwestern Medical School, Dallas, USA. He has been vice president, Pakistan Society of Gastroenterology, and president of the Pakistan Society for the Study of Liver Disease. He has also been a member of the guidelines and publications committees of the World Gastroenterology Organization, member of the Executive Council of the Asia and Pacific Association for the Study of the Liver from 2006 to 2010, and has chaired the WHO Guidelines Development Group for Hepatitis C in 2015 and 2017. He is currently member Governing Council, World Gastroenterology Organization, co-chair of Coalition to Eradicate Viral Hepatitis from Asia Pacific, CHEP, and the member of Oversight Committee, NHEP 2030. His main research interests are viral hepatitis and liver failure. He has more than 300 published papers and more than 15 citations. H-index is 55. His current work involves HCV microelimination projects in the province of Sindh, Pakistan. He has mentored a number of the postgraduate GI trainees, PhD, and other graduate students. So it is my great pleasure to listen to Professor Saeed Hamid. Please.
Thank you, Dr. Necati, first of all, for the kind invitation, and secondly, for the effusive, I should say, introduction, which is really undeserved. But anyway, thank you so much for that. So let's start on. I hope you can hear me and see my slides. Okay. So if that is correct, I will move on. So fortunately, WHO this time has taken the lead to some extent in revising their guidelines, which needed to be revised, as I'll tell you, from 2015. So it's quite a change. Of course, hepatitis, just a few introductory slides. We know the burden of disease is extensive for hepatitis B. Nearly 1 million people die every year as a consequence. In Pakistan, the prevalence is around 2%, and infected patients are about 4.2 million. Just a few caveats before we start. We're talking about treatment of hepatitis B and management. It is a DNA virus, like other viruses, currently incurable. All patients have a remnant of HBV DNA in their livers in the form of cccDNA. HBV, funnily enough, has no natural immunity, and anti-HBs is not protective against reactivation, even high titers of anti-HBs. So this is something that we need to be aware of. So what are we trying to achieve by treating chronic hepatitis B? Of course, we are going to try to minimize liver damage, which means normalize ELT levels, lower the HBV DNA levels, which are also useful. And if we can do this, the first thing is reasonably done, changing E antigen to the E antigen negative status. But then the functional cure is much less, which means the loss of hepatitis B surface antigen and seroconversion to surface antibody. And of course, the final step would be a sterilizing cure, which is cccDNA clearance, which is at the moment elusive. So the question is mainly who to treat and who not to treat, and that is what we are discussing today. There have been attempts at simplifying as we have gone along, and this is a EASL attempt a few years ago, where they categorized the tried to simplify the various categories of the chronic hepatitis B infection, which was, of course, was quite a painful thing to do for many general practitioners and even internists and so on. So it's now E antigen positive or E antigen negative, and the two categories are if there is no inflammation or lower levels of HBV DNA. It's chronic infection. If there is inflammation along with some levels of the HBV DNA, it's chronic hepatitis, and same goes for E antigen negative disease. So the chronic infection is not treated. The chronic hepatitis is treated, and similarly for E antigen negative patients, the chronic infection is not treated, and the chronic hepatitis is treated. If you look at the WHO guidelines from 2015, this immediately tells you what the problem has been. If you look at the left-hand side, which is the care cascade, you see that in at least 5 or 6 of these categories, here is a stop where it says defer treatment and monitor. So it's only one category of people who would automatically go into treatment from here, and that would be patients with cirrhosis who have DNA positivity more than 20,000, and they would be immediately treated. All the other categories would have a stop here to defer treatment and monitor. And that has been the reason why there has been such a low treatment rates for hepatitis B across the world since for many years. These are on the right hand side of the slide. It's a small table here, but just have a look. In 2022, only 13% of the 254 million people with chronic hepatitis B infection were diagnosed, and only 3% had been treated. And we've already alluded to the reasons of the guidelines being very complex, still major gaps in testing and treatment uptake, And there are a lot of regional differences in demographics and epidemiology, which we'll talk about in a little while, which needs to be taken into account. For example, liver cancers at younger age in sub-Saharan Africa, 75% of HB surface antigen HBV DNA less than 2,000 international units per ml in sub-Saharan Africa. So there are regional differences that we need to account for when we're talking about global guidelines. There is emerging evidence that there is emerging evidence that there is ongoing HBV DNA integration as we go along, and therefore this continues well into adulthood. And we know about the challenges, which is limited access to HBV DNA in LMICs, and therefore low uptake of and also the low uptake of hepatitis birth dose vaccine in these areas. So with this in mind, a guidelines group was developed by WHO. It was my honor to be co-chair along with my colleague Wendy Spearman from South Africa. We were a large group, 30 to 40 experts from all WHO regions, medical specialties, patients included, and this is the regional breakup of the group. So just to say a couple of words about the distinctive features of the WHO guidelines. These are mainly intended for low and middle income countries. So this is not the highest level of evidence that we are looking for. This is more pragmatic and more generalizable, and therefore that is, I think, what is the strength of these guidelines. They are generalized, concentrated epidemic settings for which they are useful. Other guidelines, for example, the SSLD, EASL, are high-income countries, and that is where the WHO guidelines differ. The target audience is mainly national program managers, but we know that a lot of clinical people also use these guidelines in the normal daily practice. The approach is a public health approach. It is simplified and standardized approaches, and there are preferred regimens. And whereas the other society guidelines may be very individualized in terms of treatment and multiple treatment options. Grade formulations are used. The grade process is used for formulating recommendations, and that looks at a number of features that I will talk about later. The composition of the guidelines committees is also different. 50% LMICs, program managers, civil society, patients, and so on. So I think those are some of the differences that we need to remember. Okay, so I'm having trouble moving my slides here. Okay, so this is just one slide about the grade process. We start with a PICO question, which is population, intervention, comparison, and outcomes, and this then goes through a rigorous process of recommendations, and the recommendations are important to remember that they are either strong or conditional. And there could be strong recommendations with high, moderate, or low level, even low quality of evidence that the recommendations could be strong. And I'll show you in a minute why that is possible. For conditional recommendations, of course, the evidence is lower, although this also could be a high quality of evidence, but still a conditional recommendation. So a lot of work, these are very extensive guidelines, and a lot of work, background work went into the development of all the databases. 15 systematic reviews, and here is some of the reviews that happened. There was modeling when reviews were not available. Landscape, access, and costs are always an important area. And then acceptability, values, and preferences, 4 surveys and 3 literature reviews. And this is, as I said, an integral part of the WHO guidelines, which has a lot of weightage to it in the final recommendations. So we work through an evidence to decision table framework. This is the question, and then this is the judgment, and this is what is put to the guidelines committee and debated about what should be, how this should be labeled: large, moderate, small, trivial, varies, uncertain, etc., etc. So you go through each of the PICO questions and each of the interventions and grade this according to the decision table. Okay, so these are 29 recommendations in all, which include 14 new recommendations, including the updates. So I don't have time to go through all the 29 recommendations. I thought we will just pick up some of the important ones. So non-invasive fibrosis assessment, who to treat, first-line treatment, the PMTCT, mother-to-child transmission, simplifying diagnosis, and simplifying service delivery. That is what we will concentrate on. And let's start with the who to treat, because that is, of course, the basis of the recommendations by itself. So there are 4 recommendations, and if you just as a broad overview, you can see that there is only one recommendation that is now dependent on an HBV DNA level. The others are dependent on other parameters other than HBV DNA, because that, as I said earlier, was the biggest access challenge for many situations. So the first recommendation: if there is evidence of significant fibrosis. And what do we base this on is an APRI score of greater than 0.5, which, or if there is transient elastography, greater than 7 kilopascals, and greater than 0.5 signifies greater than F2 fibrosis. The systematic review has just been published in the Lancet only a couple of weeks ago. If you care to look at that and find out the basis of what, how much the emphasis is placed on the APRI score, if in making a recommendation for treatment. So with this recommendation, we believe 20 to 25% of surface antigen people will come into treatment. Or if there's an HBV DNA which is more than 2,000, remember the previous guidelines were more than 20,000. This is now more than 2,000, and an ALT which is above the upper limit of normal. For men and for women, it's slightly different. This is a strong recommendation. For adults, at least for adolescents, it's a conditional or low recommendation because there was not that much data to consider. If there are presence of co-infections such as HIV, hepatitis D, hepatitis C, family history of liver cancer, extrahepatic manifestations, this becomes an indication for treatment as well, irrespective of the DNA levels or the ALT levels. In the absence of access to an HBV DNA, persistently abnormal ALT levels can also be a recommendation for treatment, and some people would obviously want to contest this because this could be anything else as well, NAFLD, etc., etc. But we believe that if surface antigen is positive, the persistent ALT levels are persistently abnormal, one can certainly think of doing this if there is no access to HBV DNA levels. So this we can debate and come back in a little while. So this is the systematic review which looked at natural history of chronic hepatitis B according to HBV DNA level, ALT levels in adults. The middle graph is looking at pooled incidence rates according to a single baseline HBV DNA. And as you can see, less than 200, there isn't anything much happening in terms of cirrhosis, HCC, or liver-related deaths. But once you start to go beyond 2,000, which is the gray bar here, that is where it starts to rise. And of course, it rises with more than 20,000 and more than 200,000, etc. Similarly, if you look at the ALT levels, slightly more heterogeneous, but still the same. The higher the ALT level, the higher the risk of adverse outcomes like cirrhosis, HCC, and liver-related deaths. So this was again based on a systematic review that is still to be published, but which should soon be published. This is the efficacy of antiviral treatment according to HBV DNA and ALT levels in adults. And it's a busy slide. I would just like you to concentrate on this lower lower table, which is the intent to treat an analysis for the HBV DNA levels and so on. So if the HBV DNA is less than 2,000, you need to treat 1,190 patients to prevent 1 liver-related deaths. Similarly, you need to treat 137 patients to prevent cirrhosis and 210 to prevent HCC. So if you go to 2,000 to 20,000, the number decreases dramatically. So you need to treat only 59 patients to prevent 1 liver cancer. You need to treat 21 patients to prevent 1 cirrhotic patient, and you need to prevent. You need to treat 182 to prevent liver-related deaths. And of course, to 20,000 to 200,000 is the best figure. So we believe that the 2,000 to 20,000 is a good sweet spot where numbers needed to treat significantly change. So that's what we have stuck with. If you look at these expanded treatment eligibility, the key messages are that modeling suggests that the rate of treatment goes up significantly when you implement these guidelines in many settings. For example, this is Ethiopia, this is Pakistan, and you can see the right-hand side, the bars are much higher, suggesting that the rates of treatment have gone up compared to the previous numbers. Non-invasive tests, just a very quick word. We believe it, and this paper is now published. As I said, the APRI score is recommended. Transient elastography, of course, is preferable if it is available, and this is a strong recommendation with moderate certainty of evidence, and therefore we base the significant fibrosis on an APRI score of more than 0.5, as already mentioned. So what this is, if you go back and compare the new algorithm to the old algorithm, where I mentioned to you that this is a stop here for most people in these boxes, this is now only one stop here, which is an HBV DNA of less than 2,000, a persistent anomaly LT, which may kick off a wait and monitor model or monitor action. All the other categories are now included in the treatment area, and therefore this is really quite a drastic change, we think. Although it may not be drastic enough for everyone. Not much to say in terms of first-line antiviral therapies. Tenofovir digoxil or TAF is recommended as a preferred regimen. In some areas, we understand that the triple combination of TDF with other HIV medications will also be recommended. We don't immediately recommend TAF because in most LMICs it is a bit more expensive than TDF, and therefore it may be recommended for people with established osteoporosis or impaired kidney function, and for children greater than 12 years of age. So moving on to PMTCT. The updated recommendation is that where HBV DNA or e antigen testing is available, prophylaxis with TDF is recommended for HBV pregnant women with an HBV DNA of more than 200,000. And this is an updated recommendation. This is not a new recommendation. The new recommendation is that in settings where neither HBV DNA nor e antigen testing is available, prophylaxis with TDF for all HBsA pregnant positive women may be considered. This is, of course, a conditional recommendation with low certainty of evidence. It is preferable, we are saying, to start from the second trimester rather than the third trimester, because we believe that, there is evidence to show that some of these values may be so high that they are not completely controlled if you start in the third trimester of pregnancy. Moving on to this side, the main message here is that while you are dealing with these women, please see if any of the 4 categories of recommendations that we've talked about of starting treatment are relevant to these people. If they are, they just continue with these medications with HPV treatment rather than stopping after the birth of the child. So there are, of course, other implementation considerations here, because we absolutely need to push increased coverage of hepatitis B birth dose vaccination, which should be a priority, and there should be universal triple testing for pregnant women wherever that is possible. And there needs to be simplified, integrated care for these women who may be doubly or triply infected with these viruses. So HBV DNA testing and reflex testing, of course, reflex testing is recommended. Point of care, we don't have too many options. There is Cefiad, and there is 1 or 2 other formulation of makes which are now recommended, WHO approved. But still, this is a lacunae which persists because this is an important one. This is a new recommendation, hepatitis D testing, who to test and how to prioritize. So we are recommending a universal testing approach for all individuals who are surface antigen positive. But of course, if there is a population priority testing approach, that is also possible in setting where a universal antibody testing is not feasible, because either the laboratory is not there or there is not such a high prevalence of the disease. Now, we believe that this is important because it will not just streamline the epidemiology of hepatitis delta for us, which is a big issue at the moment, but also it will pick up patients who need to be followed closely for severity of disease until we get some good therapeutics going here. So how to test the antibody test, and of course followed by a reflex HDV RNA if the antibody is positive. Coming on to service delivery, there needs to be a public health response. There's lack of direct evidence to inform recommendations on service delivery with hepatitis B. So that is a lacunae. There are very few interventional studies and therefore limited outcome data across the entire cascade. So systematic reviews to identify different service delivery models for hepatitis B care are important, and we can make adaptations from this existing HIV literature to support the hepatitis B service delivery models. There can be many service delivery models, and I'll just avoid this for lack of time. So implementation priorities are scale up of testing and case finding, updating of the national guidelines with adoption of recommendations informed by the local context, widespread education and awareness raising campaigns, and we would like to promote wide access to training and capacity building and opportunities for cost reductions for hepatitis B meds and diagnostics. Remember, this is a long-term infection requiring long-term treatment and therefore a significant commitment financially. Just to acknowledge the guidelines group and the WHO steering committee. Philippa Easterbrook was the main person, the pivot for all this extensive amount of work, a large number of academic and other institutions involved, and as I've already mentioned, a huge GDG group which was very well representative of many areas and countries. Thank you very much for your attention, and happy to answer questions later. Thank you.
Thank you very much for your excellent lecture, Dr. Saeed. So let me check any questions or not. Okay, Dr. Ramadan Al Halis said that thanks to you. Still, we don't have any questions. Maybe I can ask you one question, Dr. Saeed. Already we discussed this matter together with you. for example, in Turkey, we cannot apply this WHO guidelines because already governmental rules already inhibit to use this kind of guidelines. So, for example, in these guidelines, elastography levels should be higher than the 7, or APRI index should be higher than 0.5. So these kind of criteria cannot be used in Turkey, but I am very sure that some other countries also cannot be used. So what do you think? How do we solve this kind of problems to use this kind of guidelines?
So, Professor Nejati, the implementation is a real and live problem because, as I said, these and as you know, these are long-term treatments, and therefore the programs are hesitant to do this. But I mean, as I indicated, the data that only 3% of hepatitis B patients have been treated so far globally. And that is really a tremendous opportunity lost, we believe. And therefore, simplification as much as possible is needed. I mean, there was a very strong community voice when we were doing this to say that every person who is surface antigen positive should be put on antivirals. And of course, that seems to be a drastic step at the moment. But then these are sort of steps towards a universal coverage of hepatitis B treatment. We know the Chinese guidelines, which are well simplified, but they depend entirely on the HBV DNA performance of the HBV DNA levels, which we are trying to sort of bypass because of the cost, and secondly because of non-availability. So that is the challenge. I think we need to find the right sort of approach to this in countries where this may be implementable, and in countries which may find it difficult to implement these guidelines. We understand that.
Okay, thank you so much. I know you had a Ramadan too, so maybe what is the time now for the Ramadan?
It is 9:30 p.m. at the moment.
Okay, so already passed?
Yes, already passed. Yes.
Oh,
yes.
okay, it's
okay.
Then maybe I would like to mention that we have donated 3 young plants to the Turkish Foundation for Combating Erosion, Afforestation, and the Protection of Natural Assets Foundation under your name. So when you come to 10 years later, then these trees will grow up and you can see your name on these trees.
Thank you so much. Yeah, that is wonderful.
Very, very simple. How do you say? This is a simple gift maybe for you, but meaningful, I mean.
Of course.
So
very thoughtful of you. Thank you.
Thank you very much. Okay, I will send the certificate to you later on.
Great, thank you.
Okay, so now maybe move on to another speaker, Professor Gish. Professor Gish is a fellow of the American Association for the Study of Liver Disease, American Society of Transplantation, and American College of Physicians. He has served on the editorial boards of American Journal of Gastroenterology, Hepatology, Journal of Hepatology, Digestive Disease and Science, and Gastroenterology, among many others. He co-authored a published public health policy for liver health in Vietnam, focusing on HBV, and is also assisting with the development of viral hepatitis healthcare policies in Georgia, Armenia, and the Philippines. He was a major early contributor to decipher methods for the detection of the hepatitis B and C virus and characterizing their epidemiology and clinical presentation in humans. He was involved in studies that led to genotype classification strategies and methods now in use worldwide. He has published more than 700 original articles, abstracts, and book chapters, citations more than 18,737, and all-time H-index score is 71. Professor Gish is currently the medical director of Hepatitis B Foundation in Doylestown, Pennsylvania. He is an adjunct professor of medicine at the University of Nevada, Schools of the Medicine in Las Vegas and in Reno. He serves as an adjunct professor of pharmacy at the Skaggs School of Pharmacy and Pharmaceutical Sciences at the USCD, a clinical professor of medicine at Loma Linda University. In addition, he is a medical director of American Pacific Health Foundation in San Diego. He's a staff physician at the La Mestra, a federally qualified health center in San Diego. Dr. Gish also serves as a board member of the Vietnam Viral Hepatitis Alliance. So it's really great honor for us to have this Dr. Robert Gish in this meeting. Thank you very much for your coming. Then I would like to ask you to your presentation.
Fantastic, Professor Örmeci. That was a great introduction, and I do want to thank Dr. Saeed Hamid for that great WHO review. And indeed, simplification is, as much as possible, going to make our lives much easier. Drastic steps, I think, are needed, as Dr. Hamid described. We have this problem where the death rate from hepatitis B hasn't changed over the last 20 years. We've had 15 or 20 different guidelines come out, and nothing's changed. 2 people dying every minute. So we need something simple on the front end. And what I'm going to talk about today is the future. There is a cure in sight. We're going to talk first about functional cure, but we even have steps beyond that we're going to talk about. These slides are quite complicated, so I'm going to give just a top line on each slide to try to stay in my 20-minute time slot. But these slides are shareable through this single topic conference, through Dr. Örmeci and the APASL system, as well as through my website. I recommend that you subscribe to my newsletter. Go to my website, hit the button, you'll get a newsletter maybe 3 times a month, and my website has many resources. All right, let me see if I can figure out how to get the slides to go forward. Here are my disclosures. Very involved in the hepatitis B drug development world. As you know, the current goals of therapy are suppress virus, prevent cancer, prevent cirrhosis and death. But we have many other endpoints to be thinking about, including reducing stigma, infectivity, improving quality of life, really a patient-centric focus. And that's where this simplified approach is super important for at least first-line therapy right now, which is suppressive therapy. The next phase is this optimal, I call it generation 2 endpoint, which is DNA suppression, S antigen loss, and off treatment. There's some other guidelines or some other endpoints that people have discussed, and we'll get back to that in just a moment. I'd like you to think just for a moment about this life cycle. In some ways, this complicated life cycle is good because it gives us lots of targets. On the other side, this virus has a great way of being sequestered in the nucleus with cccDNA, of integrating into the host liver cell genome and producing lots of surface antigen. So it gets complicated, and this virus has been in humans for over 40,000 years. Hepatitis C has probably been in humans for 150 years. So this virus is clever along the lines of what you see with HIV, and that's why it's taking us so long to get to a functional cure. Definitions of cure: sterilizing, which means eliminating cccDNA, the complete cure, getting rid of all integrated HBV DNA, this functional cure. And of course, we want this combination, sterilizing, complete, and functional. There has been a bit of a back down recently where we talked about a partial cure where they remain surface antigen positive. E antigen remains negative, and HBV DNA is undetectable, and ideally that there's a reset of surface antigen to a lower level, less than 100. We came up with this idea in terms of a consensus process because we weren't getting much results on the functional cure side. We wanted a parallel or separate path forward for drug development. Surface antigen production, depending on E positive, comes off cccDNA, but in E antigen negative disease, more than 50% of surface antigen is derived from integrants. So we really need to be able to target that integrated virus, viral production, RNA translation to protein. And there's some hope along these lines with new drug development that's there. We still talk about 6 months for sustained response, whichever of these endpoints that you wish to discuss. But the next wave of therapy is finite therapy. Finite therapy means a year or less, and you'll see some data with some interesting results from even 6 months of treatment. We know that S clearance is possible, but S seroclearance spontaneously is about 0.5% per year per patient, and treatment with nukes, it's about 1 to 2% per year. We need something much better, but of course this reduces the risk of cirrhosis, cancer, and importantly, stigma. Surface antigen loss means individuals can re-enter society, relationships, work, decrease or remove discrimination. So this is an endpoint that's not just a virus, it's not just a hard endpoint, but it's a patient-focused endpoint. We must keep in mind that we should be patient-centric when we're developing guidelines, we're dialoguing about treatment, developing new treatments. Quant S, I do on every single patient that I see every single year, and that's my recommendation that quantitative S antigen be part of your practice because this is important in new drug development. There's lots of data on this slide. I just wanted to hit this high point, how important Quant S is on each patient each year. It's useful today, it's useful with nukes, it's useful with interferon, and it's useful for future drug development. Nuke therapies, I mentioned, very low rates of S loss, but we are changing outcomes with our nukes. We know that. Why isn't everybody being treated who's DNA positive? We have these complex guidelines that are evidence-based, requiring high levels of evidence before making a move. But hepatitis C, we treat everybody. HIV, we treat everybody. I believe that the Chinese guidelines are very close to that point, and WHO has made a major step forward, but I still think there's another step towards simplicity. Now let's move into the future look. We want to suppress DNA. We want to suppress a variety of hepatitis B protein production. We want to suppress surface antigen, core antigen, E antigen, X antigen. We want to suppress viral RNA and eventually have an immune modulation step, either naturally or with new therapies. But it will require combination therapy for our next wave. It could be a 3 or 4 drug combination. Of course, this will be complicated. It'll be expensive when it comes out, but that's the way it is with all drug development. We move stepwise through this process, and eventually we can benefit the world. Today, you can buy a nuke in many, many countries for hepatitis B treatment for $50 for an entire year of treatment. And this, as you've heard, has a cost-effective modeling at these low price points. DAAs, we got used to that word with hepatitis C, but we need to be acting at entry. We need to be acting at packaging. We need to be acting at the cccDNA level. We need to be acting at this integrant expression of HBV RNA. And of course, it will be for this clever virus a combination of direct, indirect, and immunomodulatory. So at least 3 legs on the chair, probably 4 legs, I think, in the next wave to get surface antigen loss rates over 40% and therapy at 1 year or less. It's going to be a little complicated. Now, when these entry inhibitors, specifically monoclonal antibodies, came out, which are in development by countries like Vir, Arbutus, there's companies in China, what I call HHH, there's other companies in this space. I was very, very skeptical. Blue Jay is in this space also. I didn't believe that these were going to work, and I was wrong. They're very interesting how these bind the virus, block entry, and become like a vaccinal-like effect with immune modulation. That's why we're seeing very interesting results on treatment, S antigen suppression on treatment as high as 70%. And you'll be hearing more about these as off-treatment data emerges. We can also target the core protein. The core protein is essential for packaging and recycling and regeneration of cccDNA. So the first generation of CAMs had problems with relapse, with resistance. There are even some CAMs that have signals of liver toxicity. But second generation CAMs, which I'll show you in a moment, did result in some good data. Now, one of the problems was history. Back in the CAM data with J&J, with Janssen, mixed with an siRNA from Arrowhead that actually targeted two different triggers, the CAMs looked like they interfered with the siRNA response or the efficacy of the siRNA. And Janssen eventually came out of drug development, stopped this, and this told us a lot. There's a very complicated story behind the CAM-siRNA interaction, which is time for another discussion. But Aligos came out with a second generation, and I'm just going to point you to these graphs in the middle of this, looking at the S antigen reduction in that beautiful graph in that blue line. So we're starting to see with CAMs on treatment, lack of resistance, and on treatment S antigen reduction that actually can be in the multi-log state. I want to highlight on here, it's not just S antigen we're looking at or E antigen, but we're looking at correlated antigen, a complex assay from Fujiri Bio that looks at 3 different endpoints. And Abbott's developing what I call a pure core antigen assay that's either phosphorylated or unphosphorylated. So lots going on in test and assay development as part of drug development that I think eventually is going to be helpful for our patients. In the US today, I can order a correlated antigen quantification through Mayo Clinic, so I can actually order that on a patient and potentially use that clinically. RNA interference, lots of companies in this space, and antisense oligonucleotides, ASOs, I think are also very exciting. I think this will be one of the 4 cornerstones of this combination therapy. And you could target many different messenger RNAs with these siRNAs. The ASOs are very interesting because not only do they suppress these different viral sequences, but the ASOs act through an immune modulation step. So it's almost like you're giving, or you are giving, one drug having 2 different dichotomous effects that can come back and help control. And I'll get back to Bepi in a few moments as we go down that ASO pathway. There's many studies that GSK has been pushing forward with the Bepi going into phase 3. But just look at this right side, just a very simple message. With less than 24 weeks, I'm saying less than 24 weeks because in some arms there was 12 weeks of treatment, we're getting S loss. That's undetectable. This is less than 0.05 and a 10% rate compared to what you see with nuke therapy, which is in the 3% rates. So we're tripling our S loss rate on treatment. And there's other studies, which I won't go into in great detail here, with other combinations, including interferon, where you're getting between 9, 15, and 20% rates of S loss, depending on different combinations. So I believe that Bepi will be first to market for our next wave of treatment, and it'll be combination therapy. Back to S antigen quantification, this drug works best if that S antigen quant is less than 1 to 3,000. There's a little bit of a window there that the farther you are below that 3,000 threshold, much higher rates of S loss. So we'll be using S antigen quantification to choose patients for new treatment, and also going down the road of maybe 4 drugs for high S antigen, 3 drugs for low S antigen levels, and then making a decision about the role of interferon, which, including with Bepi, shows better off-treatment long-term response. In other words, cutting in half the relapse rate. So interferon is not gone. Interferon will be part, I believe, of the near-term combination therapy. This is the B Together study where peg interferon reduced relapses following Bepi treatment. And this is quite impressive here. And you can look in the lower code where green was the baseline S antigen less than 3,000 and yellow baseline S antigen less than 1,000. And the percent of participants who maintained that S antigen loss. This is 24 weeks after the end of treatment. So off-treatment response, quite encouraging. Please quantitate S antigen annually on all your patients. Get one baseline and then just set them up for quantification. This is available through the Roche platform, Abbott platform. Other platforms have reliable, high-quality S antigen quantification that you can trust in your practice. Now, I'm going to come back to siRNAs and just say, well, there's a little bit of an Achilles heel to this medication. There seems to be a saturation that takes place, that the best reduction we can get is 2 to 3 logs. Although I will tell you that there's some siRNAs in practice that can get into the 4 to 5 log range now, as people target different delivery systems, better what we call binding to the RISC complex, and maybe longer acting in the RISC complex as well. So really keep your eyes and ears open. I've been working with siRNAs for over a decade. I started working with Arrowhead in 2011. I still think this is a major advance for managing our patients. This is looking at the siRNA in combination with a CAM. I mentioned that earlier, and there appeared to be a challenge of this CAM interaction with the siRNA. So my message here is we have to be cautious and really be thinking about adaptive study designs. Who's the right patient for siRNA? What is the right CAM? Do we need to be using second generation CAM, which I discussed before with oligos? And it may be different patients require different combination therapy based on baseline viral characteristics, including QuantS, quantitative correlated antigen, quantitative HBV RNA. Now, we heard a lot about these NAPs over the last decade, and the sad news about the NAPs is that they work, but I haven't seen a path forward to getting these medications to the clinic. The medication appears to be heavily wrapped up in phase 2 studies and hasn't gone through a formal phase 3 process that would take us to licensing this drug and using the drug. So that's one part of the challenge, even though you see these profound levels of S reduction and off-treatment S loss. But there's also an issue of flares. On the right side, you can see ALT levels in this treatment phase that can go up as high as 800. That's going to make you and I and our patients nervous. And more importantly, it makes the regulators nervous to see this level of enzyme change, although liver function, specifically bilirubin, did not change in these studies. So NAPs may have a hope. We're not clear for a path forward. Well, there's a lot of excitement out there about gene editing, or we're going to use the term gene silencing. I'm going to cover this quickly, but there is so much going on. There's 5 different companies in this space. This CRISPR-Cas has been discussed over the last decade. There have been challenges with delivery, concerns about off-target effect, but gene editing now holds hope, because on this slide, I'm discussing an ARCUS technology. This is derived from an algae instead of CRISPR, which is derived from E. coli. And this ARCUS gene editing eliminates cccDNA and inactivates integrated HBV DNA. And the first 3 patients have been dosed with the first and low dose of this ARCUS P gene technology. There was a press release a week ago on that. I'm advisor for this company, so I'm excited, of course. And no adverse events, and 2 out of the 3 patients with a low dose, single dose, had a profound drop in S antigen quantification. So we have excitement coming. There's another company called Tune, T-U-N-E, Tune TX, that has an epigenetic modifier, also targeting both cccDNA and expression and integrated expression. So watch Tune TX, watch this precision company. There's another company called Chroma that's in this space. So lots going on here with what we call epigenetic modification, gene silencing, gene editing. And I think this will be a major step forward, but we have about 2 to 3 years to find the roadmap with these drugs. The companies are great, advisors are great. We thank our patients. I'll be wrapping up now with these immune-related strategies. Interferon alpha, upper right corner, is still around. I just showed you use with that BEPI data. We have TLRs that come in and out of favor, other intracellular pathways that are also targeted, your checkpoint inhibition. We even have oral checkpoint inhibitors that are liver delivered that are there. Therapeutic vaccines from a company called Virion, which I'll talk about briefly. These monoclonal antibodies. We have engineered T cells that are going on. Very, very excitement there. And I really believe these checkpoint modifications can bring about this T cell activation that we need. One thing I'd like to mention here is getting rid of that word immune tolerant. It's a great paper by Dr. Boni from Italy, B-O-N-I, who really highlights that that term is out of date. And if we're evidence-based, which Dr. Hamid emphasized before, we have evidence we should not be using the word immune tolerant anymore. These patients are not immune tolerant. They just have different levels of immune activation and immune recognition. So it's very important to be changing this antigen recognition through these co-stimulatory pathways and bringing the T cells into play. And there's a lot of mechanistic things that are built on these different slides, but I think this is a hope for one of these 4 legs on our table, on our chair. Just to wrap things up, I think I've stayed close to my 20 minutes, Dr. Örmeci, is to go to my website. This is a little bit of a long label here, but in my Dropbox is a roadmap of 65 different medications that are in development for hepatitis B today. We're going to be talking about excitements in Beijing around this in a few weeks. A lot more going on. EASL, especially in May. DDW also will be having some new information. EASL and AASLD are going to come out with guidelines that are really evidence-based, but not as patient-centric as I think WHO is, or the Chinese guidelines, which to me, the Chinese guidelines and WHO are the 2 headlights on my truck to getting to hepatitis B suppression and hepatitis B cure. I want to thank the Single Topic Conference, Apostle, Dr. Örmeci for having me. I look forward to seeing everybody in Beijing or potentially in Istanbul or your wonderful country, and also at EASL. Thank you so much, and ready for next steps.
Thank you very much, Dr. Gish, for your excellent and magnificent lecture. So it's really very, very useful for the Turkish Society of Hepatology. I just checked the questions part. There's a one, okay. Bepirovirsen seems good drug for HBV. What are the most common side effects of it? It is possible to use bepirovirsen with NUC analogs. This is the question.
So the question has to do with side effects of nukes or side effects of the new therapies? I'm sorry.
They ask, is there any side effect of bepirovirsen?
Yeah, so BEPI is a great question. There are 2 adverse events that we need to be alerted to. There is a subset of patients who have ALT flares on BEPI. There's a debate whether these ALT flares are immune-related or related to some other viral drug interaction. So that's being sorted out, but no patient has had any liver synthetic dysfunction. It is an injectable, so there are some local injection site reactions, but so far, no major concerns from a safety perspective. And in fact, all the drugs that I've mentioned today, none of these have any major safety signals, and we'll be watching, of course, as we get into phase 2 and major phase 3 studies. Great question.
As you mentioned that looks like in the future, hepatitis B virus infections treatment looks like a combination treatment. But can you guess how long does it take to becomes a real drugs for the human being?
So what's the timeline? So as I mentioned, As I mentioned, Bepi is going into phase 3 studies, multiple phase 3 studies. And I think that Bepi should be available probably US first and then EU second, probably sometime around 2027, maybe late 2026. So Bepi will be the lead. That will be combination. We'll be selecting patients on viral and host characteristics. The rest of the drugs are all in phase 1B and a few in phase 2 right now. So I really think that we're looking to 28 or 2029 to have multiple choices on the market. And then globalization of these drugs usually takes about 5 years. So I'm thinking 2030 to 2035 where we'll have much more global access. But you know, the crystal ball may not be right.
Yeah. So really, once more time, I'd like to thank to you for your great contribution to our society. There are many thanking written here, so but no other questions. That means everyone very well understand your lectures. So the last one will give you just a symbolic gift. We have donated 3 young plants to Turkish Foundation for Combating Erosion, Afforestation, and the Protection of the Natural Assets Foundation under your name. So maybe 20 years later, inshallah, I hope you will come to Turkey so many times. Then you can see your trees in the forest under your name, I mean.
Shukran, Dr. Örmeci.
Okay, so I will send you the certificate of your gift. Okay.
Fantastic.
So one more time, thank you very much for your great contribution to us. And one more time, I would like to thanks to audience because even we had the Ramazan, they just gave us the time for this nice meeting. Okay, one more time, I would like to thanks all of you. So I hope to see you in 2026 in Turkey. Great. You are great.
Thank you very much. Thank you. Bye-bye.
Bye-bye. Thank you very much.